What happens when you get a letter from your pharmacist?
Find out today on Medical History Mysteries.
Okay, so I've been holding this letter just
Okay.
for today to talk with you because you know that you're my specialist in all things medicine and pills and drugs and local anesthetics and whatever. So, okay. I got a letter from my pharmacist. And remember, we were talking on our podcast about this. You were saying how you should have an open communication with your pharmacist and you guys can kind of go back and forth and collaborate for your patient's care. And I was like, yeah, that sounds really great. And here we are, several weeks later, I get a letter from a pharmacist. Now, this is what happened. Here's the backstory. I have a patient that came to me because she has TMJ pain. So I prescribed her Flexeril for this pain. Short term, really to kind of hold her over because we're making her a night guard. And so to hold her over between the day I met her and the day she's getting her night guard, we are doing photobiomodulation, PBM, with a laser on her TMJ. And we prescribed Flexeril because she has taken it before and it has provided her relief. Now, I get this letter and it says muscle relaxants such as cyclobenzaprine are poorly tolerated due to anticholinergic effects, risk of sedation, increased risk of fracture, and questionable efficacy in patients 67 years of age or older. If possible, please avoid use in this population. My patient is 71, or she'll be 71 very soon. I can't believe I got a letter. What do I do?
Well, I'm glad you got a letter from the pharmacist because that's an awesome thing. We've been talking about this for a while now, this multidisciplinary approach to medicine. So, yes, your pharmacist sends you a note. Consider it a love note. How about that? From your friendly neighborhood pharmacist to you saying, hey, let's be on the lookout for possible adverse effects of these medications. Even though you prescribe them in the best and of faith, ultimately every medication can have adverse effects and side effects, especially in older folks. We've got to be really careful because older folks have lots of systemic diseases. They have lots of medications on average, not every one of them. And so as a result, if let's say one medication a patient's taking has anticholinergic effects and you prescribe the medication that has anticholinergic effects and they're used together, well, let's double the anticholinergic effect. When I say anticholinergic, I mean things like dry mouth and urinary hesitancy and things that are already maybe commonplace in someone who's older. So that is one point that is well taken. Now, keep in mind also that these drugs can cause, uh, as I like to say, and as your pharmacist like to say, the potential for falls because they can cause dizziness and drowsiness and unsteady gait. So we get it. But at the same time, while we're considering all that, realize that you didn't have many options to begin with. I mean, you've used the PBM, which is amazing, right? That's a great way to treat TMJ. And you do have the night guard at the ready, right? You've got it being made right now. So a short, days supply amount of cyclobenzaprine seems like a good option here because really, what else would you do to keep this patient out of pain? The problem, and I think I understand where the pharmacist is coming from here, is that drugs that we call skeletal muscle relaxants really don't directly relax skeletal muscles. They're not true skeletal muscle relaxants. They're more central nervous system depressants that, as a result of suppressing the activity in the brain, thereby cause relaxation of your skeletal muscles. So you could think of them as sort of like drugs that make you relax mentally so that you'll relax physically. Okay, well, in that case, I can understand why these drugs can also become habit forming. And that's a concern also in older folks because number one, some older folks do abuse medications, it's possible. And two, sometimes again, in combination with other drugs they take, that can increase that risk of dependency and substance use disorder as well. So overall, wouldn't have a problem with the pharmacist sending you a letter. They are basically telling you try to avoid using this drug in someone in that age group, but you're the doc. You're the clinician, right? You make those amazing decisions you make every day. and your decision-making process, you found that this may be the one drug to use temporarily. And we can only hope that once the mouth guard is in place, she won't need the cyclopenzaprine anymore, and off we go.
Is there something else I coulda, shoulda prescribed instead?
It's really hard with TMJ. Ibuprofen and acetaminophen, which are the stalwarts of pain management in dentistry, really don't work that well on TMJ. I've seen botulinum toxin used for TMJ, but again, that may be something you don't want to use in an older patient who may be immunocompromised. It's a very slippery slope we're trying to navigate here, because we've got to give her something. But in this case, from what I gather, you only prescribed 10 tablets, right? You didn't prescribe a lot. And you did look her up in the database, which I'm sure, right? Yes, very well done.
I did.
Very well done. So you did your due diligence. And again, in your professional decision making, in your opinion, you felt this was the right agent for treating that condition. I don't think you could have done any better. One thing I would recommend, and I'm sure you did it already, but I'd recommend anybody listening, document, right? I prescribed the cyclobenzaprine for this reason. Okay, it doesn't have to be a long essay. It could be 2 sentences, but at least then later on, if someone would go back and say, well, why'd you prescribe the cyclobenzaprine? You could say, well, here are my options. What did I have left? This is why I made the decision I did.
So part of my decision-making process, besides the fact I did do my due diligence elsewhere, was that she had taken it before and it had provided her some relief. So for me, I feel like if they've taken it before, they've had a positive reaction from it, and it was taken safely and it helped with the problem, I thought that was a great choice.
I could not and should not second guess that decision. You are ultimately the prescriber, but kudos to the pharmacist for providing you with the extra information, because maybe you wouldn't have known all those things. And hey, now maybe that would have helped you make a better decision or a different decision for this patient. Although I think you've made the best decision possible, based on everything you've told me.
Thank you. So I am going to respond to this pharmacist, and maybe I will have made a new friend. So thank you for that. I think this was great advice. And even though I get to spend all of this time with you shooting medical history mysteries videos, I learned from you too. So thank you.
Another mystery solved. How about that? Well done.
Perfect. All right, onward. Okay, everybody, for Medical History Mysteries, I'm Pamela Maragliano-Muniz. With me as always,
Tom Viola. Thank you so much, everybody. Good seeing you again.
see y'all next week. Bye.